This is long run into most comprehensive pharmacology audiobook, best for boards. Let's talk about enzyme kinetics, are you ready? Enzymes typically follow Michaelis-Menten kinetics, where the reaction rate depends on how much substrate is available. Now listen carefully, Km, or the Michaelis constant, refers to the substrate concentration needed to reach half of the maximum velocity, which we call 1/2 Vmax, and here's the key point, you should remember that Km is inversely related to the enzyme's affinity for its substrate, meaning the lower the Km, the higher the affinity. Vmax, on the other hand, is directly proportional to the total enzyme concentration, so if you increase the amount of enzyme, the maximum velocity increases as well. Most enzymes follow a hyperbolic reaction curve, but if you see a sigmoidal curve, that usually points to positive cooperativity, where binding one substrate molecule makes it easier for the next to bind, like in the case of aspartate transcarbamylase. Now let's break it down further, using variables. S represents the concentration of the substrate, while V stands for the velocity of the reaction. At half of Vmax, the substrate concentration equals Km. Are you following me? Then let's talk about enzyme inhibitors and how they change the game. There are two main types you need to know, competitive and non-competitive inhibitors. A reversible competitive inhibitor binds to the enzyme's active site, competes directly with the substrate, and resembles the substrate in structure. This competition increases the Km, because you need more substrate to reach the same velocity, but here's the catch, Vmax stays unchanged, because adding more substrate can eventually outcompete the inhibitor. Now listen carefully, a non-competitive inhibitor doesn't bind the active site at all. Instead, it binds somewhere else, altering the enzyme's function no matter how much substrate is present. This doesn't change the Km, since the enzyme's affinity for its substrate is unaffected, but it reduces the Vmax, meaning the maximum possible velocity drops because some enzymes are permanently disabled by the inhibitor. When you look at a Lineweaver-Burke plot, which is a double reciprocal graph used to analyze these kinetics, here's what you should notice, a point closer to 0 on the y-axis indicates a higher Vmax, and a point closer to 0 on the x-axis signals a higher Km, meaning lower affinity. In this plot, reversible competitive inhibitors produce lines that intersect, while non-competitive inhibitors produce lines that don't cross. You should remember this, competitive reversible inhibitors look like the substrate, bind to the active site, and can be overcome by increasing substrate levels. They leave Vmax unchanged, but they increase kilometer. In contrast, competitive irreversible inhibitors also resemble the substrate and bind the active site, but they cannot be overcome by adding more substrate, and they permanently reduce enzyme activity. Lastly, non-competitive inhibitors do not resemble the substrate, they don't bind to the active site, and they cannot be overcome by substrate increase. They leave Km unchanged, but reduce Vmax significantly. Finally, let's connect this to pharmacodynamics. Competitive inhibitors tend to reduce potency, because you need more drug to get the same effect, while irreversible competitive inhibitor and non-competitive inhibitors reduce efficacy, because no matter how much drug you give, the maximum effect is lower. Let's begin with bioavailability, often abbreviated as F, which refers to the fraction of an administered drug that actually reaches the systemic circulation. Now listen carefully, when a drug is given through an intravenous route, bioavailability is 100%, because it goes directly into the bloodstream. But when taken orally, the bioavailability is usually less than 100%, and that's due to two main reasons, incomplete absorption from the gut and what we call first-pass metabolism, which happens when the drug is partially broken down in the liver before it can circulate. Are you following me? Good, because now let's talk about how we calculate bioavailability. It's done by comparing the area under the curve, or AUC, in a plasma concentration over time graph. More specifically, F equals the AUC for oral administration multiplied by the 4 dose, then divided by the oral dose multiplied by the AUC for 4, and the result is multiplied by 100 to express it as a percentage. Now let's shift to volume of distribution, or VD, which is a theoretical concept that describes how much of a drug spreads throughout the body compared to its concentration in the blood. This value tells us whether a drug mostly stays in the bloodstream, or whether it distributes widely into tissues. Liver and kidney diseases can increase the volume of distribution, mainly because they reduce protein binding, so more free drug is available to enter tissues. Drugs with a low VD tend to stay in the blood, especially if they are large, charged, or tightly bound to plasma proteins. A medium VD suggests distribution into extracellular fluid, usually seen with small hydrophilic drugs. And if a drug has a high VD, it spreads into all body tissues, including fat, especially if it's small, lipophilic, or tissue-bound. Hemodialysis, you should remember, is most effective for drugs with a low VD, since those remain in the bloodstream. Now listen carefully, clearance, or CL, is another crucial concept. It refers to the volume of plasma from which the drug is completely removed per unit time. Clearance depends on how well the liver, kidneys, or even the heart are working, and it can be reduced in cases of organ dysfunction. You can calculate clearance by dividing the rate of drug elimination by the plasma drug concentration, or, more simply, it equals VD multiplied by the elimination constant, which we call Cu. Are you ready for half-life? The half-life, or T1/2, is the time it takes to eliminate half the amount of drug from the body. This is important because it determines how long a drug stays active. Now you should remember this: when a drug is infused continuously, it takes about 4 to 5 half-lives to reach steady state, which is the point where the amount of drug entering the system equals the amount being eliminated. And to reach 90% of steady state, it takes around 3.3 half-lives. In first-order kinetics, where the rate of elimination is proportional to the drug concentration, half-life is calculated by multiplying 0.7 with the VD, and then dividing that by the clearance. Now let's talk dosage, because this is what determines how we treat patients. A loading dose is given to quickly reach the desired plasma concentration, and it equals the target plasma concentration, or CP, multiplied by the VD, then divided by the bioavailability F. On the other hand, a maintenance dose is used to keep drug levels steady over time, and it equals CP multiplied by clearance and by the dosing interval, which we call tau, then divided by F. Tau represents the time between doses, and for continuous infusions, it doesn't apply. And here's something important you should remember: in cases of renal or liver disease, the maintenance dose should usually be reduced, but the loading dose often stays the same, since the volume of distribution isn't significantly affected. Finally, the time it takes to reach steady state depends mainly on the drug's half-life, and not on the actual dose or how often the drug is given. Now let's talk about drug metabolism. Are you ready? When a drug enters your body, it often undergoes chemical changes before being eliminated, and this transformation is known as metabolism. Drugs can be metabolized through phase I reactions, phase II reactions, or both, and these steps don't always follow a fixed order. That means phase I doesn't always have to come before phase II. In some cases, a drug might only go through one phase, or even go through phase II first. Phase I reactions, which are usually CYP450 enzyme dependent, involve processes like oxidation, reduction, and hydrolysis. These reactions often convert a lipophilic drug into a slightly polar metabolite, which may still be active or inactive. However, these products may include reactive oxygen metabolites, which can sometimes be harmful if not further processed. Now listen carefully: phase II reactions come in when the body wants to make these drugs even more water-soluble, and they include methylation, glucuronidation, acetylation, and sulfation. These reactions usually attach a polar group to the drug, resulting in a very hydrophilic, water-soluble compound that's easier to eliminate. But there's an exception: acetylated metabolites may not be very polar. You should remember this: elderly or geriatric patients often lose their phase I metabolic capacity first, meaning they may rely more on phase II pathways. Also, some individuals are slow acetylators, which means they process drugs like isoniazid more slowly, leading to an increased risk of adverse effects because their rate of metabolism is reduced. Now let's talk about elimination, the final step where the body gets rid of drugs, usually through the urine, sweat, or bile. There are two major types of drug elimination you should understand: zero-order elimination and first-order elimination. In zero-order elimination, the rate of drug elimination is constant, regardless of how much drug is in the blood. That means the same amount is cleared in every unit of time, and the plasma concentration drops linearly over time. You can think of drugs like phenytoin, ethanol, and aspirin, especially at high or toxic concentrations, as classic examples. These follow what's called capacity-limited elimination, and here's a fun way to remember it. Just think of the acronym PEA, which stand for phenytoin, ethanol, and aspirin because a P is round, just like the zero in zero-order elimination. Now let's compare that to first-order elimination, where the rate of elimination depends on the concentration of the drug. So instead of removing a constant amount, the body clears a constant fraction per unit time. As a result, the plasma drug concentration decreases exponentially, not in a straight line. This type of elimination is also called flow-dependent, and it applies to most drugs used in clinical practice. Are you following me? Great, because when you graph these, the difference is clear. In zero order, the slope remains constant over time, while in first order, the slope gets smaller as the concentration drops. So, in zero order, the body just keeps clearing 2 units per hour, no matter what. But in first order, it might start by clearing 4 units per hour when drug levels are high, then drop to 1 unit per hour, and later down to half a unit, as the drug concentration goes down. Now listen carefully, because this part is really important. The way our body eliminates drugs through urine depends a lot on whether the drug is ionized or not. You should remember this: ionized, or charged forms of drugs, get trapped in the urine and are eliminated quickly, while neutral, non-ionized forms can often be reabsorbed back into the bloodstream. Let's start with weak acids, such as phenobarbital, methotrexate, and aspirin, which is also known as salicylate. These are more likely to exist in their ionized form when the urine is alkaline, which means less acidic. So, if someone overdoses on one of these weak acids, we can give them sodium bicarbonate to raise the pH of the urine. This makes the drug more ionized, traps it in the urine, and speeds up elimination. Here's a chemical way to look at it: RCOOH, which is the non-ionized acid form and lipid-soluble, becomes RCOO- plus hydrogen, which is the ionized, water-soluble form that gets trapped and eliminated. You should definitely keep that in mind. Now let's flip the coin and talk about weak bases, like tricyclic antidepressants, or TCAs, and amphetamines. These are trapped more easily in acidic urine. So, in theory, if someone had a toxicity involving a weak base, and they were in severe alkalosis, we might use something like ammonium chloride to make the urine more acidic, which helps ionize the base and trap it in the urine. For weak bases, the equation looks like this: RNH3+, which is the ionized and trapped form, can convert into RNH2 plus a hydrogen ion, where RNH2 is the lipid-soluble neutral form. But when the environment is more acidic, the balance shifts toward the ionized, and that means faster elimination. Now, you should know something important about TCA toxicity. The first thing we do is treat with sodium bicarbonate, but not to increase elimination. Instead, it's to counteract the dangerous effect of sodium channel blockade in the heart, which is a key part of how TCAs cause cardiac toxicity. So yes, it helps the heart, but it doesn't speed up how fast the drug leaves the body. Are you still with me? Good, because now let's explain pKa, a key concept that tells us the pH at which a drug is 50% ionized and 50% non-ionized. Think of it as the point where the drug is balanced between being trapped and being reabsorbed. The pKa reflects the strength of a weak acid or base, and how it will behave in environments of different pH. To make it visual, imagine a graph where the x-axis is pH, and on the y-axis, we see how much of the drug is ionized. For a weak acid, as the pH rises above the pKa, more of the drug becomes ionized and therefore trapped. For a weak base, the opposite happens: it becomes more ionized as the pH drops below the pKa. So, the farther the environment's pH is from the drug's pKa, the more ionized the drug becomes, and the more it stays in the urine. That's the key to controlling drug elimination through urine pH manipulation. Now listen carefully, because understanding the difference between efficacy and potency is key when talking about how drugs work. Even though these two terms often get confused, they describe two very different things. Let's begin with efficacy, which is all about the maximum effect a drug can produce. This is sometimes called intrinsic activity, and it's represented by the y-axis value on a dose-response graph, often labeled as Emax. So, when you see a drug with a high peak effect on the graph, that means it has high efficacy. You should remember this: efficacy is not related to the amount of drug you need, it's simply about how strong the effect can be once the drug is fully active. For example, partial agonists, even at their best, can never reach the same effect level as full agonists. That means they have lower efficacy, even if they might be very potent in small doses. So, higher on the y-axis means higher efficacy, and that's how we compare the maximum potential of one drug versus another. Now let's talk about potency, which is something different. Potency refers to the amount of drug needed to get a certain effect, typically measured as EC50, the dose that gives 50% of the drug's maximum response. On a graph, potency is represented by the x-axis position, so when the drug's curve shifts to the left, it means you need less of the drug to get the same result. That means lower EC50, which means higher potency. Are you following me? Because here's the key takeaway: a drug can be very potent but not very effective, and another drug can be highly effective but require a larger dose, meaning it has low potency. These two concepts, efficacy and potency, are not dependent on each other. To visualize it, imagine two curves on the same graph. One reaches a higher point on the y-axis, that drug has greater efficacy. But if another curve reaches 50% of its effect with a smaller dose, shifted more to the left on the x-axis, that drug is more potent. So always remember, efficacy is how big the effect can get, while potency is how much drug it takes to get there. Now listen carefully, because understanding how drugs interact with receptors is essential to mastering pharmacodynamics. Let's start with agonists. These are drugs that bind to a receptor and activate it to produce a biological effect. But what happens when you introduce antagonists into the mix? First, imagine giving a regular agonist. As the dose increases, the effect increases, and eventually it reaches a maximum. But now, if you add a competitive antagonist, things change. This antagonist binds to the same site as the agonist, blocking it, but only temporarily. If you increase the amount of agonist, you can still overcome the antagonist and reach the same maximum effect. This means that potency is reduced, but efficacy remains unchanged. For example, think about diazepam, a GABA-A receptor agonist. If you add flumazenil, a competitive antagonist, you'll need more diazepam to get the same calming effect, but eventually, it can still get there. So again, competitive antagonists shift the dose-response curve to the right, meaning lower potency, but they don't reduce the efficacy. Now let's talk about non-competitive antagonists. These are different. They bind to a different site or change the receptor in a way that can't be overcome by just adding more agonist. So, no matter how much agonist you give, the maximum effect is reduced. In this case, the efficacy goes down, but the potency stays the same. A classic example is norepinephrine, which stimulates alpha receptors. If you add phenoxybenzamine, a non-competitive antagonist, the maximum effect of norepinephrine is limited. That's because phenoxybenzamine binds permanently or allosterically, so you can't just outcompete it by adding more agonist. Now let's explore partial agonists. These drugs bind to the same receptor as full agonists, but they only produce a weaker response, even when all receptors are occupied. So their efficacy is lower, even though their potency may vary. A good example is buprenorphine, which is a partial agonist at the opioid mu receptor. When compared to morphine, a full agonist, buprenorphine activates the receptor, but not to the same extent. And don't forget about inverse agonists. These are special because they bind to receptors that are already active even without a drug. An inverse agonist will actually reduce the baseline activity of the receptor. So unlike regular agonists, which increase activity, and antagonists, which just block it, inverse agonists turn the activity downward. A practical example is H1 antihistamines like diphenhydramine, which not only block the histamine receptor but also reduce its activity below the normal baseline. Are you ready for one more important concept? Let's talk about the therapeutic index, often abbreviated as TI. This is a measure of drug safety and is calculated by comparing the toxic dose to the effective dose. Specifically, TI equals TD50 divided by ED50, where TD50 is the dose that causes toxicity in 50% of people, and ED50 is the dose that produces the desired effect in 50%. So what does this number tell us? Well, the higher the therapeutic index, the safer the drug. That's because there's a bigger gap between what helps and what harms. But drugs with a low therapeutic index need to be watched closely. For example, medications like warfarin, theophylline, digoxin, lithium, and many antiepileptics all have narrow therapeutic windows, which means the dose that helps and the dose that harms are close together, so even small changes can be dangerous. In animal studies, instead of TD50, we often use LD50, which is the lethal dose in 50% of animals. But whether we're talking toxicity or lethality, the idea is the same. The therapeutic index helps us judge how safe a drug is to use. So remember, therapeutic index shows us the margin between effectiveness and danger, and the wider that window, the better and safer the drug is for patients. Now listen carefully, because drug interactions aren't always just about one medication working alone. Sometimes, two or more drugs can change each other's effects in surprising ways, and you need to understand how these modifications work in real-life treatment. Let's begin with something simple, the additive effect. This happens when the combined action of two drugs is just the sum of their individual effects. In other words, if drug A and drug B each do their job separately, then putting them together gives you exactly what you'd expect, nothing more, nothing less. A great example is aspirin with acetaminophen. When taken together, their pain-relieving effects simply add up. It's like saying 2 plus 2 equals 4. Next, there's the permissive effect. Here, one drug doesn't do much on its own, but it's needed to make another drug work better. Think of it like a backstage crew member, making the spotlight shine just right. For example, cortisol alone may not raise blood pressure, but it enhances the effects of catecholamines like epinephrine. So, cortisol is permissive, it allows the other drug to do its full job. Now let's move on to something a bit more dramatic, the synergistic effect. This is when the combination of two drugs gives you more than what you'd expect. It's like saying 2 plus 2 is greater than 4. An excellent example is aspirin used with clopidogrel. Together, these drugs dramatically reduce clot formation more than either drug alone could. That's true synergy. Then there's potentiation, which is a close cousin to synergy, but with a twist. Here, one drug does nothing on its own, but it makes another drug much more effective. Imagine one person just holding the door open, while the other walks through to do the job. A classic example is carbidopa, which doesn't treat Parkinson's symptoms itself, but it helps levodopa work better by preventing it from breaking down too early. That's 2 plus 0, giving you more than 2. Of course, not all drug combinations are helpful. Sometimes, you get an antagonistic effect. This means that the drugs work against each other, so the combined effect is less than the sum of what they do alone. It's like two people pulling in opposite directions. A perfect illustration is morphine combined with naloxone. Morphine relieves pain, while naloxone blocks opioids, so together, they reduce each other's impact. This is 2 plus 2 equals less than 4. Finally, let's talk about a strange but important phenomenon called tachyphylaxis. This refers to a rapid decrease in response to a drug after it's given repeatedly or continuously. In other words, the more you use it, the less it works, and it can happen quickly. A familiar example is using a nasal decongestant like oxymetazoline. At first, it opens your airways, but with repeated use, it actually causes rebound congestion, meaning the effect drops off sharply, and you feel worse than before. So, to summarize, drug effects can be additive, permissive, synergistic, potentiated, antagonistic, or tachyphylactic, each with its own clinical importance. And understanding these relationships can help you choose the right combinations, avoid dangerous interactions, and maximize therapeutic benefit for your patients. Now let's talk about the amazing world of autonomic pharmacology, where your body's involuntary functions are coordinated by two major systems, the sympathetic and parasympathetic nervous systems. In the parasympathetic system, signals begin from the brainstem or spinal cord, traveling through long preganglionic neurons that release acetylcholine, or ACH for short. This neurotransmitter then activates nicotinic receptors on short postganglionic neurons, which also release ACH, but this time to act on muscarinic receptors located on smooth muscle, gland cells, or cardiac tissue. Remember, cranial nerves 3, 7, 9, and X, along with the pelvic splanchnic nerves, are part of this calming system. In contrast, the sympathetic system starts with short preganglionic neurons, which also release ACH onto nicotinic receptors. These connect to long postganglionic neurons, which typically release norepinephrine, or NE, acting on adrenergic receptors like alpha and beta types. But there are exceptions. For instance, sweat glands are actually sympathetic, yet they're activated by ACH, not NE. So even though it's fight or flight, it still results in a cholinergic-induced cold sweat. Also, the adrenal medulla is directly stimulated by a preganglionic sympathetic neuron to release epinephrine and norepinephrine into the blood, making it part of the endocrine arm of the system. Now let's look more closely at the receptors themselves. First, the nicotinic acetylcholine receptors. These are ligand-gated ion channels. When activated, they allow sodium and calcium to flow in, and potassium to flow out. These come in two main forms, NN, found in autonomic ganglia and the adrenal medulla, and NM, found at the neuromuscular junctions of skeletal muscle. Then we have the muscarinic ACH receptors, which are G-protein, coupled and use second messengers to carry out their effects. There are 5 types, M1 through M5, located across the heart, brain, glands, and smooth muscles. Even sweat glands, though part of the sympathetic system, have muscarinic receptors that respond to acetylcholine. Now listen carefully, because pain transmission is also heavily influenced by drugs. Nociceptive pain, which is the kind of pain you feel from a cut, burn, or injury, starts when mechanical, thermal, or chemical stimuli activate special pain receptors. These are known as transient receptor potential vanilloid receptors, and they allow calcium to enter the cell, which then triggers sodium channels to open. The signals then travel to the brain through A delta fibers, which are responsible for sharp, quick pain, or C fibers, which transmit dull, throbbing pain. Pain processing involves 4 major steps. First, there's transduction, where the pain signal begins. This step can be blocked by local anesthetics, alpha-2 agonists, NSAIDs, acetaminophen, and even glucocorticoids. Second, there's transmission, which carries the signal along the nerves. This too can be blocked by local anesthetics, opioids, and alpha-2 agonists. Third, modulation alters the strength of the pain signal, and can be blocked by tricyclic antidepressants, SSRIs, SNRIs, and gabapentinoids. Finally, there's perception, which is how your brain experiences pain, and this can also be blocked by opioids and antidepressants. And now, let's talk about neuropathic pain, which is different. This kind of pain comes from damage or dysfunction within the nervous system itself. It involves persistent activation of voltage-gated sodium channels, and one well-known example is diabetic peripheral neuropathy, where patients feel pain even without an injury. This type of pain often requires special treatments, like gabapentinoids or antidepressants, because standard painkillers may not be effective. Now let's talk about how your body controls urination, or as we call it, micturition. This process is carefully regulated by a special center in the pons, which balances the sympathetic and parasympathetic nervous systems. When the sympathetic system becomes more active, it encourages urinary retention, keeping the bladder closed and relaxed. On the other hand, when the parasympathetic system takes over, it promotes urine voiding, letting the bladder contract and empty. This coordination involves multiple nerves. The pelvic nerve, which is parasympathetic, activates M3 receptors on the detrusor muscle, leading to bladder contraction. Meanwhile, the hypogastric nerve, carrying sympathetic signals, targets beta-3 receptors on the detrusor muscle to relax it, and alpha-1 receptors on the internal urethral sphincter to keep it tight. Finally, the pudendal nerve, which is somatic, controls the external urethral sphincter using nicotinic receptors, giving you voluntary control when you need it most. Now listen carefully, because certain drugs act directly on these receptors to treat bladder problems. Muscarinic agonists, like bethanechol, stimulate M3 receptors to contract the detrusor muscle, increasing bladder emptying, and they're used in urinary retention. In contrast, muscarinic antagonists, like oxybutynin, block M3 receptors, relax the detrusor, and are helpful in urgency incontinence, where the bladder contracts too much. Then we have sympathomimetics, like mirabegron, which activate beta-3 receptors, allowing the bladder to relax and hold more urine, making them useful in treating urgency incontinence as well. And for patients with benign prostatic hyperplasia, or BPH, we often use alpha-1 antagonists, like tamsulosin, which relax the smooth muscles in the bladder, neck and prostate, improving urine flow and reducing obstruction. Now let's shift gears and talk about where these adrenergic receptors are found and what they do. Alpha-1 receptors, located in vascular and visceral smooth muscle, cause vasoconstriction and contraction. Alpha-2 receptors, found on pancreatic cells, presynaptic nerve terminals, and salivary glands, reduce insulin release, neurotransmitter output, and even saliva production. Moving on to beta receptors, beta-1 is mainly in the heart and kidneys, increasing heart rate, force of contraction, and renin secretion. Beta-2 receptors, found in the lungs, heart, liver, blood vessels, and pancreas, promote bronchodilation, increased heart rate, glucose release, vasodilation, and even insulin secretion. And don't forget beta-3 receptors, which are active in adipose tissue, stimulating fat breakdown, and in the bladder, promoting relaxation. Now listen carefully, because this part is all about G-protein, coupled receptors and the powerful second messenger systems they activate. These receptors are categorized by their associated G-protein type, GQ, GI, or GS, and they each have specific targets and effects. Let's begin with the adrenergic receptors. Alpha-1 receptors, which are GQ-linked, cause contraction of vascular smooth muscle, they also constrict the pupillary dilator muscle, leading to mydriasis, and they tighten intestinal and bladder sphincters. Alpha-2 receptors, which are GI-linked, inhibit sympathetic outflow, reduce insulin release, suppress lipolysis, increase platelet aggregation, and decrease aqueous humor production in the eye. Beta-1 receptors, linked to GS, raise heart rate and contractility, boost renin release, and increase lipolysis. Just remember, there's one heart. Beta-2 receptors, also GS-linked, lead to vasodilation, bronchodilation, enhanced lipolysis and insulin release, increased glycogen breakdown, lowered uterine tone or tocolysis, elevated aqueous humor production, and increased potassium uptake by cells. Remember, there are two lungs. Beta-3 receptors, again GS-linked, promote lipolysis, enhance thermogenesis in skeletal muscle, and help the bladder relax. Now let's talk about the cholinergic system. M1 receptors, using GQ, are involved in higher cognitive functions, they activate the enteric nervous system, and they increase exocrine secretions. M2 receptors, which are GI-linked, slow down the heart rate, decrease AV node conduction, and reduce atrial contractility. M3 receptors, acting through GQ, increase glandular secretions, gut movement, bladder contraction, bronchoconstriction, and vasodilation. They also cause pupillary constriction or meiosis, and promote ciliary muscle contraction, helping with accommodation. Next, we move on to dopamine receptors. D1 receptors, which are GS-linked, help relax renal vascular smooth muscle, and they activate the direct pathway in the striatum. D2 receptors, using GI, modulate neurotransmitter release, especially in the brain, and they inhibit the indirect pathway of the striatum. Then we have the histamine receptors. H1 receptors, which are GQ-linked, promote bronchoconstriction, stimulate mucus production, increase vascular permeability, cause vasodilation, and trigger itching or pruritus. H2 receptors, linked to GS, stimulate gastric acid secretion in the stomach. Now let's finish with vasopressin receptors. V1 receptors, through GQ, cause vascular smooth muscle contraction. V2 receptors, using GS, boost water reabsorption in the kidney by increasing aquaporin 2 in the collecting tubules, and they also stimulate the release of von Willebrand factor or VWF. Are you following me? Great, because now we dive into the intracellular cascade triggered by these receptors. When GS-linked receptors, like beta-1, beta-2, beta-3, D1, H2, or V2, are activated, they stimulate adenylyl cyclase, converting ATP into cyclic AMP, which activates protein kinase A, leading to various responses like increased contractility, fat breakdown, or water retention. In contrast, when GI-linked receptors, such as M2, alpha-2, or D2, are stimulated, they inhibit adenylyl cyclase, which lowers cyclic AMP, slowing down certain cellular processes. And with GQ-linked receptors, like H1, alpha-1, V1, M1, and M3, activation stimulates phospholipase C, which then splits PIP2 into IP3 and DAG. IP3 raises intracellular calcium, while DAG activates protein kinase C, together leading to smooth muscle contraction and other actions like gland secretion. Now let's talk about how norepinephrine release is controlled in the autonomic nervous system. You should remember this: norepinephrine, or NE, when released from a sympathetic nerve terminal, can actually regulate its own release. How? By binding to alpha-2 autoreceptors located on the presynaptic membrane, which creates a negative feedback loop, reducing further NE release and keeping things in balance. But things get really interesting when drugs like amphetamines come into play. Listen carefully: amphetamines hijack the norepinephrine transporter, or NET, to enter the presynaptic terminal. Once inside, they don't stop there, they move into neurosecretory vesicles by using another transporter called VMAT, or vesicular monoamine transporter. Inside the vesicles, amphetamines displace NE, pushing it out of storage. And as the concentration of norepinephrine rises inside the presynaptic terminal, it reaches a point where the direction of NET is reversed. This reversal causes norepinephrine to be expelled into the synaptic cleft, even without a nerve signal. This surge leads to the strong stimulatory effects seen in people taking amphetamines, and that's how the drug mimics an intense sympathetic response. Are you following me? Good, because there are many noradrenergic stimulants that work in different ways but produce similar effects. These include amphetamines, serotonin-norepinephrine reuptake inhibitors or SNRIs, cocaine, tricyclic antidepressants or TCAs, ephedrine, and even MDMA. All of these increase norepinephrine activity, either by preventing its reuptake, boosting its release, or both. But it's not just norepinephrine. We also have dopaminergic stimulants, like methylphenidate, cocaine, and of course, amphetamines, which enhance dopamine transmission, often leading to increased focus, reward, and euphoria. Then there are serotonergic stimulants, including SSRIs, SNRIs, cocaine, and again amphetamines, which elevate serotonin levels and contribute to mood elevation and emotional effects. And now, let's not forget about the cholinergic system. Certain drugs, like acetylcholinesterase inhibitors, for example donepezil, act as cholinergic stimulants, because they prevent the breakdown of acetylcholine, increasing its availability in the synapse. On the other hand, botulinum toxin serves as a cholinergic inhibitor by blocking the release of acetylcholine, leading to muscle relaxation or even paralysis. There's more: some drugs inhibit VMAT directly. One example is tetrabenazine, which blocks dopamine, norepinephrine, and serotonin from being stored in vesicles, thereby decreasing their availability and activity in the nervous system. Are you ready for a quick biochemical recap? Let's walk through the synthesis and transmission steps. It starts with tyrosine, which converts to dopa, then to dopamine, and finally into norepinephrine. For acetylcholine, choline combines with acetyl-CoA, and its breakdown is handled by acetylcholinesterase, or ACHE. After these neurotransmitters do their job in the synaptic cleft, they either diffuse away, get metabolized, or undergo reuptake, and that's where many of the drugs we mentioned exert their action. Now listen carefully. NET, the norepinephrine transporter, plays a huge role in clearing NE from the synapse. Its reversal, triggered by amphetamines, causes NE to flood the cleft. VMAT, on the other hand, determines how much NE or dopamine gets packaged for release. And if these transporters are disrupted or manipulated, the whole balance of neurotransmission can shift dramatically. Now let's talk about cholinergic agents, which are drugs that mimic the action of acetylcholine, or ACH, in the body. You should remember this: while these drugs can be therapeutically useful, they should be used with caution, especially in patients who already have asthma, chronic obstructive pulmonary disease, or peptic ulcer disease, because they may worsen these conditions. Are you ready to explore the direct agonists? Let's begin with bethanechol, which activates smooth muscle in the bladder and promotes urination. It doesn't get broken down easily by acetylcholinesterase, and importantly, it only works on muscarinic receptors, not nicotinic ones. That's why we say, Bethany, call me to activate your bladder, because it's used to treat urinary retention. Now, let's move on to carbachol. This one's a carbon copy of acetylcholine, but unlike ACH, it's resistant to breakdown. It's used to constrict the pupil and is helpful during eye surgery to induce intraoperative miosis. Next is methacholine, a drug that stimulates muscarinic receptors when inhaled. It's mostly used in a challenge test to help diagnose asthma, by provoking bronchoconstriction in sensitive individuals. Then there's pilocarpine, and here's a useful memory tip: you cry, drool, and sweat on your pilo. This drug contracts the ciliary muscle in open-angle glaucoma and the pupillary sphincter in closed-angle glaucoma. It crosses the blood-brain barrier, and it's very effective in stimulating sweat, tears, and saliva. So, it's used to treat glaucoma and dry mouth, especially in conditions like Sjogren syndrome. Now listen carefully. Let's shift to the indirect agonists, which are acetylcholinesterase inhibitors. These drugs don't activate the receptors directly, but instead, they prevent the breakdown of acetylcholine, allowing more of it to stick around and do its job. One key group includes donepezil, rivastigmine, and galantamine. These increase acetylcholine levels and are commonly used as first-line treatments for Alzheimer's disease. A good mnemonic is, Dona Riva forgot the gala. Now let's talk about neostigmine. This one also increases acetylcholine, but because it has a positive charge, it does not cross the blood-brain barrier. It's used after surgery to treat ileus, urinary retention, and myasthenia gravis, and it can also reverse neuromuscular blockade caused by anesthesia. Another drug, pyridostigmine, boosts acetylcholine levels and improves muscle strength. It's used as a long-acting treatment for myasthenia gravis, but since it can have side effects like excess secretions, it's often paired with drugs like glycopyrrolate or hyoscyamine to counteract those unwanted effects. And here's a handy phrase: pyridostigmine gets rid of myasthenia gravis. Then we have physostigmine. Unlike neostigmine, this one freely crosses the blood-brain barrier, and that's important when treating anticholinergic toxicity, like an overdose of atropine. So remember, physostigmine fixes atropine overdose. Now listen carefully, because this part is very important. Anticholinesterase poisoning is often caused by organophosphates, which are chemicals commonly found in insecticides like fenthion, parathion, and malathion. These agents irreversibly inhibit acetylcholinesterase, and poisoning is typically seen in farmers or agricultural workers. The effects can be intense. Muscarinic symptoms include diarrhea, urination, miosis or pupil constriction, bronchospasm, bradycardia, emesis, lacrimation, sweating, and salivation. A helpful way to remember them is with the mnemonic dumbbells. Now, how do we treat this? You should remember that atropine, a competitive inhibitor, can be used to reverse the muscarinic effects, and since atropine crosses the blood-brain barrier, it can also relieve central nervous system symptoms like agitation or confusion. But that's not the whole picture. There are nicotinic effects too, such as neuromuscular blockade, which works similarly to how succinylcholine acts. These effects are reversed by pralidoxime, a drug that can reactivate acetylcholinesterase by dephosphorylating it, but only if given early. And it's crucial to combine pralidoxime with atropine, because giving it alone might actually make the symptoms worse, temporarily. Also, keep in mind, pralidoxime does not cross the blood-brain barrier, so it won't fix CNS issues. Finally, we can't forget the central nervous system effects of poisoning. These may include respiratory depression, lethargy, seizures, and even coma, which makes early intervention absolutely critical. Now let's talk about muscarinic antagonists, which are drugs that block the effects of acetylcholine at muscarinic receptors, and are used for a wide range of conditions. Are you ready to explore them system by system? Starting with the eye, drugs like atropine, hematropine, and tropicamide are used to produce pupil dilation, or mydriasis, and cycloplegia, which means paralysis of the ciliary muscle, making it easier to examine the retina during eye exams. Now let's move to the central nervous system. Here, benztropine and trihexyphenidyl are useful. They're used in Parkinson disease, and also to treat acute dystonia, which is a sudden, painful muscle spasm. You can remember this with the phrase, "park my benz." Next up is the GI and respiratory systems, where glycopyrrolate plays a dual role. When given parenterally, or by injection, it's used preoperatively to reduce airway secretions. But when given orally, it helps reduce drooling, and can even be used to treat peptic ulcers. Now listen carefully, because hyoscyamine and dicyclamine are also important in the GI tract. They work as antispasmodics and are especially helpful for managing symptoms of irritable bowel syndrome. Moving on to the respiratory system, drugs like ipratropium and tiotropium are bronchodilators. They help manage asthma and chronic obstructive pulmonary disease. Tiotropium lasts longer than ipratropium, so remember that for long-term control. Now for the genitourinary system, there's a group of drugs that help reduce bladder spasms and treat urge urinary incontinence, also known as overactive bladder. These include oxybutynin, tolterodine, solifenacin, and flavoxate. A simple way to remember them is, they make the bladder soft, which stands for solifenacin, oxybutynin, flavoxate, and tolterodine. And don't forget scopolamine, a drug that works in the CNS and is used to prevent motion sickness. It's especially helpful on long trips or sea voyages. Now let's take a closer look at atropine itself. It's a classic muscarinic antagonist and is often used to treat bradycardia, or a slow heart rate, and it's also applied in ophthalmology. In the eye, it dilates the pupil and causes cycloplegia. In the airway, it reduces secretions and causes bronchodilation. In the heart, it increases heart rate. In the stomach, it decreases acid secretion, and in the gut, it slows motility. Finally, in the bladder, it reduces urgency, especially in conditions like cystitis. Are you following me? Good, now let's talk about the adverse effects. These drugs can cause a rise in body temperature, mainly due to reduced sweating. They also speed up the heart rate, cause dry mouth, and lead to dry, flushed skin, along with constipation, cycloplegia, and confusion or disorientation. Older adults may be at risk for acute angle closure glaucoma, especially because of mydriasis. Men with prostatic hyperplasia may experience urinary retention, and infants are especially prone to hyperthermia. Here's a great mnemonic to remember the anticholinergic toxicity symptoms. It goes like this: hot as a hare, because of the fever. Fast as a fiddle, due to the rapid heart rate. Dry as a bone, because of the dry mouth and skin. Red as a beet, due to skin flushing. Blind as a bat, because of pupil dilation and loss of accommodation. Mad as a hatter, because of CNS disorientation, and finally, full as a flask, because of urinary retention. And now, one last thing, Jimson weed, also known as datura, can cause a classic anticholinergic toxicity. Its hallmark symptom is Gardner's pupil, which is a persistently dilated pupil caused by accidental exposure while handling the plant. Are you ready? Let's talk about sympathomimetics, which are drugs that mimic the effects of sympathetic nervous system activation. These can be divided into two main types, direct sympathomimetics and indirect sympathomimetics. Now listen carefully. Starting with direct sympathomimetics, let's look at albuterol, salmeterol, and terbutaline. These drugs primarily target beta-2 receptors more than beta-1 receptors, which means they relax smooth muscles in the lungs with only a slight increase in heart rate. Albuterol is typically used for acute asthma or COPD attacks, while salmeterol is preferred for long-term or serial treatment of asthma and COPD. Terbutaline, on the other hand, is helpful for acute bronchospasm in asthma and can also be used for tocolysis, which means stopping premature labor. Now let's talk about dobutamine. This drug works mainly on beta-1 receptors, with lesser effects on beta-2 and alpha receptors. It slightly lowers blood pressure, but increases both heart rate and cardiac output. It's commonly used in cardiac stress testing and in acute decompensated heart failure, especially when cardiogenic shock is involved, because it acts as a powerful inotrope. Are you following me? Good. Next is dopamine, which targets D1 and D2 receptors at low doses, and beta and alpha receptors at higher doses. At lower doses, it increases heart rate and cardiac output, while at high doses it raises blood pressure through vasoconstriction. It's used in unstable bradycardia and shock, offering both inotropic and chronotropic support depending on the dose. Moving on to epinephrine, this drug acts more on beta than alpha receptors. It increases blood pressure at high doses, and also raises heart rate and cardiac output. It's a key treatment for anaphylaxis, asthma, and shock, and can be used in open-angle glaucoma. At higher doses, alpha effects become more dominant, but remember, it has a stronger effect on beta-2 receptors than norepinephrine. Now let's talk about phenoldiprem, which activates D1 receptors. This leads to vasodilation, a decrease in blood pressure, and an increase in both heart rate and cardiac output. It's mainly used for postoperative hypertension and hypertensive crises. It also promotes natriuresis, which helps the body get rid of sodium, but side effects may include hypotension, flushing, headache, and a fast heartbeat. Now listen carefully, isoproterenol stimulates both beta-1 and beta-2 receptors equally. It lowers blood pressure due to vasodilation, but increases heart rate and cardiac output. It's mainly used for evaluating tachyarrhythmias, but it can worsen ischemia and has almost no alpha effects. Next is midodrine, which is an alpha-1 agonist. It raises blood pressure through vasoconstriction, but may lower heart rate and has little to no effect on cardiac output. It's helpful for treating autonomic insufficiency and postural hypotension, but may worsen high blood pressure when lying down. Then there's mirabegron, a beta-3 agonist, used for urinary urgency, incontinence, or overactive bladder. And here's a tip to help you remember it, just think mirab-3-gron, because it targets beta-3 receptors. Let's not forget norepinephrine, which primarily activates alpha-1 receptors, followed by alpha-2 and beta-1. It raises blood pressure, has a minimal or sometimes reduced effect on heart rate due to reflex bradycardia, and a small increase or no change in cardiac output. It's commonly used for hypotension and septic shock. Lastly, for this group, phenylephrine stimulates alpha-1 more than alpha-2 receptors. It increases blood pressure through vasoconstriction, lowers heart rate through reflexes, and has little or no effect on cardiac output. It's used for hypotension, in eye procedures as a mydriatic to dilate pupils, for nasal decongestion, and for treating ischemic priapism. Now let's move on to indirect sympathomimetics, which don't act directly on receptors but instead increase the amount of catecholamines like norepinephrine and dopamine available at the synapse. Amphetamine is a general agonist that inhibits reuptake and also releases stored catecholamines. It's used for narcolepsy, obesity, and ADHD. Cocaine is another indirect agonist and reuptake inhibitor. It causes vasoconstriction and provides local anesthesia. But here's a critical point: never give beta blockers to someone with suspected cocaine intoxication, because blocking beta receptors can leave unopposed alpha-1 activity, which can dangerously raise blood pressure and cause coronary vasospasm. Also, since it causes pupil dilation when the sympathetic system is intact, it can be used to confirm Horner syndrome. Finally, there's ephedrine, which works by releasing stored catecholamines. It's used for nasal decongestion, urinary incontinence, and low blood pressure. You might recognize its over-the-counter form, pseudoephedrine. Now listen carefully: sympathomimetic drugs have different effects on the body depending on which receptors they activate. Let's start with norepinephrine. This drug mainly stimulates alpha-1 receptors, which causes vasoconstriction. As a result, both systolic and diastolic blood pressures go up, and mean arterial pressure also increases. But because of this rise in blood pressure, the body responds with reflex bradycardia, which slows down the heart rate. So overall, norepinephrine raises cardiac output and pulse pressure significantly, but heart rate might actually drop a bit due to that reflex. Now let's talk about epinephrine. It stimulates both alpha and beta receptors, but it favors beta effects more. That means you get increased heart rate and cardiac output through beta-1 stimulation, and some vasodilation through beta-2 receptors. However, at higher doses, the alpha-1 effects kick in more strongly, leading to vasoconstriction and an increase in blood pressure. So before giving an alpha blocker, epinephrine causes a net pressor effect, meaning blood pressure rises. But after alpha blockade, only the beta-2 effects remain, causing vasodilation and a drop in mean arterial pressure. This is called epinephrine reversal. Are you following me? Good. Now let's move on to isoproterenol. This drug is mostly a beta agonist, stimulating both beta-1 and beta-2 receptors equally. Beta-2 activation causes vasodilation, which lowers mean arterial pressure. But in response, heart rate increases through both beta-1 action and reflex mechanisms. So overall, isoproterenol increases heart rate and cardiac output, but lowers blood pressure slightly, while widening the pulse pressure. You should remember this: phenylephrine is a pure alpha agonist, meaning it stimulates only alpha-1 receptors. It causes vasoconstriction, which increases blood pressure and may trigger reflex bradycardia. And importantly, because phenylephrine doesn't act on beta receptors, its effects are not reversed by alpha blockade. They may be blunted, but not flipped. Finally, if you compare the effects of these drugs over time, you'll notice that epinephrine initially raises blood pressure due to alpha-1 effects, but after alpha blockade, its beta-2 activity dominates and blood pressure actually drops. In contrast, norepinephrine continues to raise blood pressure because it's mostly alpha-driven, while isoproterenol causes a fall in pressure but a big rise in heart rate. Now listen carefully: beta blockers are a diverse group of drugs with names like atenolol, betaxolol, bisoprolol, carvedilol, esmolol, labetalol, metoprolol, nadolol, nebivolol, propranolol, and timolol. These medications have many uses, and their effects depend on how they influence heart rate, blood pressure, and even hormone release. Let's begin with angina pectoris. Here, beta blockers reduce heart rate and contractility, which lowers oxygen demand by the heart and helps relieve chest pain. In glaucoma, particularly with timolol, they reduce the production of aqueous humor, lowering eye pressure. Are you following me? Good, because in heart failure, some beta blockers like bisoprolol, carvedilol, and metoprolol are especially important. They block the harmful effects of stress hormones on the heart and help prevent structural changes, which improve survival and reduces mortality. When it comes to hypertension, they lower cardiac output and decrease renin secretion by blocking beta-1 receptors in the juxtaglomerular cells of the kidney. For people with hyperthyroidism or during a thyroid storm, beta blockers, especially propranolol, help control symptoms like a fast heart rate and tremors. Now let's talk about hypertrophic cardiomyopathy. These drugs reduce the heart rate and increase filling time, which helps relieve obstruction and improve blood flow. And in migraine prevention, beta blockers work by decreasing nitric oxide production, which helps stop those painful attacks before they start. Moving on to myocardial infarction, or heart attack, beta blockers lower the heart's oxygen demand in the short term and improve survival in the long term. In cases of supraventricular tachycardia, like atrial fibrillation, they slow down AV node conduction. Medications like metoprolol and esmolol are commonly used here. You should also know that beta blockers help with variceal bleeding, especially as a prophylaxis, by reducing pressure in the portal vein system. Drugs like nadolol, propranolol, and carvedilol are used for this purpose, especially in patients with liver disease with high-pressure portal circulation. But, now listen carefully, these drugs can have side effects. They may cause erectile dysfunction, bradycardia, AV block, and even worsen heart failure in some cases. On the central nervous system side, they might lead to seizures or sleep problems. Metoprolol may increase cholesterol levels, and in diabetic patients, they can mask symptoms of low blood sugar. In people with asthma or COPD, beta blockers may worsen breathing symptoms, so caution is needed. And here's something interesting, using beta blockers for chest pain caused by cocaine is controversial. There's a concern that blocking beta receptors without blocking alpha receptors might lead to unopposed alpha stimulation, but this idea isn't strongly supported by evidence. Now, are you ready for the classifications? Beta blockers can be either selective or non-selective. The beta-1 selective blockers, like atenolol, betaxolol, bisoprolol, esmolol, and metoprolol, mostly come from the first half of the alphabet, from A to M. These primarily affect the heart and are less likely to cause breathing problems. On the other hand, non-selective beta blockers, like nadolol, propranolol, and timolol, affect both beta-1 and beta-2 receptors and fall in the second half of the alphabet, from N to Z. These can affect both the heart and lungs. There are also non-selective alpha and beta blockers, such as carvedilol and labetalol, which have slightly different endings than the typical olol. These drugs block both types of receptors and are useful in certain conditions like heart failure and hypertensive emergencies. Finally, let's not forget nebivolol. It's unique because it selectively blocks beta-1 receptors while also activating beta-3 receptors. This stimulates nitric oxide production, helping to relax blood vessels and lower systemic vascular resistance, so you get a combination of heart protection and improved blood flow. Now listen carefully. Phosphodiesterase inhibitors, or PDE inhibitors, are drugs that prevent the breakdown of CMP and cGMP, which are important messengers inside our cells. By blocking the enzymes that break them down, these drugs help increase their levels, and that leads to various effects depending on the tissue and the PDE type they target. Let's start with the nonspecific PDE inhibitor, and that's theophylline. It works by stopping CMP from being broken down, so CMP levels go up. This relaxes the smooth muscles in the airways and leads to bronchodilation. It was once commonly used for COPD and asthma, but now it's rarely used due to its side effects, which include fast heart rate, irregular heartbeat, seizures, headaches, and stomach pain. Are you ready to move on? Good, now let's talk about the popular PDE5 inhibitors like sildenafil, vardenafil, tadalafil, and evanafil. These drugs increase cGMP by blocking its breakdown, which enhances nitric oxide activity and causes smooth muscle relaxation. This leads to better blood flow in the penis, making them useful for erectile dysfunction. They also help in pulmonary hypertension, and tadalafil is even used for benign prostatic hyperplasia. Side effects can include flushed skin, headaches, indigestion, and low blood pressure, especially if taken with nitrates. People often describe it as hot and sweaty, then they get a headache and maybe some heartburn. And here's a fun fact, sildenafil can cause blue-tinted vision, a side effect called cyanopia, because it also blocks PDE6 in the retina. Now let's talk about the PDE4 inhibitor, which is roflumilast. It works by increasing CMP in immune and airway cells, and it's used for severe COPD. However, it's not without side effects. It can cause abdominal pain, weight loss, and mental health issues like depression, anxiety, and insomnia. Are you following me? Great. Next is the PDE3 inhibitor, milrinone. In heart muscle cells, it raises CMP and increases calcium levels, which strengthens the heartbeat and speeds it up. This is called positive inotropy and chronotropy. And in blood vessels, it causes vasodilation, which lowers both preload and afterload. It's used in acute heart failure, especially during cardiogenic shock, but it can cause fast heart rate, irregular rhythms, and low blood pressure. Now let's finish with the so-called platelet inhibitors, which include cilostazol and dipyridamole. These increase AMP in platelets and prevent them from clumping together, making them useful for intermittent claudication, stroke prevention, and even cardiac stress testing, especially dipyridamole, which also causes coronary vasodilation. Cilostazol is actually a PDE3 inhibitor too, but because of how it's used, we talk about it here with the platelet drugs. These medications can cause nausea, headaches, facial flushing, low blood pressure, and abdominal discomfort. And here's something interesting about dipyridamole: not only does it block PDE, but it also stops adenosine reuptake by platelets. That leads to higher adenosine levels outside the cells, which further helps dilate blood vessels. The dipyridamole is also a nonspecific PDE inhibitor, leading to inhibition of platelet aggregation. Alright, let's dive into some serious stuff now: toxicities and adverse effects related to pharmacology, especially from ingested seafood toxins. These toxins can mess with your body in several ways, like triggering histamine release, completely blocking sodium channels, or even opening them and causing depolarization. So, first up is histamine poisoning, also known as scombroid poisoning. This comes from spoiled dark meat fish, like tuna, mahi-mahi, mackerel, or bonito. Here's what happens: certain bacteria in the spoiled fish use an enzyme called histidine decarboxylase to turn histidine into histamine. This reaction creates symptoms that are often mistaken for a fish allergy. You might feel a burning sensation in your mouth, experience flushed skin, itching, hives, or even breathing problems like bronchospasm and swelling. In severe cases, it can cause low blood pressure. To treat it, you'll need antihistamines, and sometimes albuterol or even epinephrine if things get intense. Moving on, let's talk about tetrodotoxin, which is found in pufferfish. Now this one is no joke. It binds tightly to fast voltage-gated sodium channels in your nerves and stops them from depolarizing, which basically halts nerve signals in their tracks. What does that mean for you? You could get nausea, diarrhea, numbness, muscle weakness, dizziness, and even loss of reflexes. There's no antidote, so treatment is purely supportive care. Next, and this one's exotic, is ciguatoxin. It shows up in reef fish like barracuda, snapper, and the moray eel. Unlike tetrodotoxin, which blocks sodium channels, ciguatoxin opens them, causing excessive depolarization. Symptoms. Well, they start off with nausea, vomiting, and diarrhea, but then things get weird. You might feel numbness around the mouth, and experience a bizarre reversal of hot and cold sensations. On top of that, your heart rate can drop, and you might face low blood pressure or even heart block. Again, treatment is supportive, so managing symptoms is the main approach. Now shifting gears, let's explore how aging changes drug metabolism, because yes, as we get older, the way our body handles medication starts to shift, and that can make standard doses too strong, leading to higher drug concentrations in the blood. Starting with absorption, here's some good news: it stays mostly the same with age. But when it comes to distribution, things start to shift. Older adults have less total body water, which means water-soluble drugs end up with a smaller volume of distribution and a higher concentration in the bloodstream. On the flip side, they have more body fat, so fat-soluble drugs spread out more, stick around longer, and have an extended half-life. Meanwhile, metabolism slows down because the liver shrinks a bit and blood flow decreases, which leads to less first-pass metabolism and slower hepatic clearance. It's important to note that phase 1 metabolism, which includes oxidation, reduction, and hydrolysis, is reduced, but phase 2 metabolism, like conjugation and acetylation, remains relatively unaffected. Finally, let's not forget excretion. As people age, their kidneys also lose some mass and blood flow, which means glomerular filtration rate drops. That causes renal clearance to go down as well, making it easier for drugs to accumulate in the body. Alright, now let's go over some life-saving treatments for specific toxins and overdoses. Are you ready? This is the kind of stuff that makes all the difference in an emergency. So, when someone overdoses on acetaminophen, the antidote is N-acetylcysteine, which works by replenishing glutathione and helping the liver detoxify. Now listen carefully, for ACHE inhibitors or organophosphate poisoning, you first give atropine to block muscarinic effects, and then, if needed, follow it with pralidoxime to reactivate the enzyme, but remember, atropine comes first. Next up, if the problem is from antimuscarinic or anticholinergic agents, you can use physostigmine because it crosses the blood-brain barrier, and don't forget to also manage any hyperthermia. If it's arsenic poisoning, go for dimercaprol or succimer, both are chelators that help pull the metal out of the body. Similarly, for benzodiazepine overdose, your go-to antidote is flumazenol, but use it cautiously, especially if there's a seizure risk. For a beta-blocker overdose, you'll need atropine, glucagon, and sometimes saline to support blood pressure and heart rate. Moving on, if the patient has been exposed to carbon monoxide, give them 100% oxygen, and if it's severe, you'll want hyperbaric oxygen therapy. When it comes to copper toxicity, think of penicillamine, or use trientine, both bind copper and help remove it. Now for something more dangerous, if it's cyanide poisoning, treat it with hydroxycobalamin, or use nitrites plus sodium thiosulfate, which help detoxify it through different pathways. In case of overdose with dabigatran, a direct thrombin inhibitor, the reversal agent is idarosizumab. For digoxin, you'll want to use digoxin-specific antibody fragments, which bind and neutralize the drug. Next, for direct factor XA inhibitors, such as apixaban, use andexanet alpha as the antidote. And for heparin, the answer is protamine sulfate, which binds to and inactivates it. Now let's talk about iron toxicity. The treatment involves chelators like deferoxamine, deferocyrox, or deferoprone, which all help the body excrete excess iron. In cases of lead poisoning, especially in children, use calcium disodium EDTA, penicillamine, dimercaprol, or succimer. These agents all help remove lead from tissues and blood. If it's mercury, again, dimercaprol or succimer are the key treatments. For ingestion of methanol or ethylene glycol, which is found in antifreeze, use fomepizole first. If unavailable, ethanol can be used, and in severe cases, dialysis may be necessary. In the case of methemoglobinemia, where oxygen delivery is impaired, you'll treat it with methylene blue, or you can also use vitamin C as a reducing agent. Now for methotrexate toxicity, which affects folate metabolism, the rescue treatment is leucovorin. If someone overdoses on opioids, the well-known antidote is naloxone, which quickly reverses respiratory depression. For salicylate poisoning, such as aspirin overdose, use sodium bicarbonate to alkalinize the urine, and consider dialysis for severe cases. Tricyclic antidepressants, or TCAs, can cause serious cardiac toxicity. In this case, give sodium bicarbonate to stabilize the cardiac cell membrane. Finally, in the case of warfarin overdose, give vitamin K for a delayed reversal, and for a more immediate effect, you'll use prothrombin complex concentrate, or fresh frozen plasma, also called FFP. Now let's shift gears and talk about cardiovascular drug reactions, because some medications can surprise you with serious heart-related side effects. Are you following me? First, we have coronary vasospasm, which means sudden tightening of the coronary arteries, and it can be triggered by drugs like cocaine, amphetamines, sumatriptan, and ergot alkaloids. To help you remember this, think of the acronym CASE. Those are the culprits that can literally spasm your heart. Next up is cutaneous flushing, which is that warm, red skin sensation, especially on the face and neck. This reaction is famously caused by vancomycin, adenosine, niacin, calcium channel blockers, echinocandins, and nitrates. You can remember it with the mnemonic Vansen, as if you're dancing, because that's what you'll feel like doing when your skin turns flushed and warm. Now listen carefully, the flushing from vancomycin is also called vancomycin infusion reaction, which was previously known as red man syndrome. It happens due to histamine release, causing a widespread, itchy, red rash. It depends on the infusion rate, so to manage it, you just slow the infusion down and give diphenhydramine to block the histamine. Moving on, dilated cardiomyopathy, which leads to a weakened and enlarged heart, can be caused by chronic alcohol use, or chemotherapy drugs like the anthracyclines, such as doxorubicin and daunorubicin. To protect the heart during treatment, doctors often co-administer dexrazoxane. Another drug to watch out for is trastuzumab, which can also contribute to this condition. Let's talk about peripheral edema, that uncomfortable swelling in the legs and ankles. This is commonly associated with dihydropyridine calcium channel blockers, like amlodipine. And now, the last and most dangerous reaction on our list is torsades de pointes, a type of life-threatening heart rhythm disorder linked to QT interval prolongation. The drugs that can cause it include methadone, antiarrhythmics like class IA and III, antibiotics such as macrolides and fluoroquinolones, antipsychotics like ziprasidone, antidepressants including tricyclics, antiemetics like ondansetron, and even antifungals such as fluconazole. Let's move on to some important endocrine and reproductive drug-induced disorders, because hormones don't like surprises, and some medications are known to stir things up. First, let's talk about adrenocortical insufficiency. This can occur when there's HPA axis suppression, usually after long-term use of exogenous glucocorticoids. And here's the catch: if you suddenly stop those steroids, the patient can plunge into an adrenal crisis, which is a medical emergency. Next is diabetes insipidus, a condition where the kidneys can't concentrate urine properly, leading to excessive urination and thirst. Two drugs that can cause this are lithium and dimeclocycline. Are you still with me? Good, because now comes gynecomastia, or breast tissue enlargement in males. This unwanted side effect can be triggered by ketoconazole, cimetidine, spironolactone, GnRH analogs or antagonists, androgen receptor inhibitors, and 5-alpha reductase inhibitors. Following that, we have hot flashes, commonly seen with SERMs like tamoxifen, clomiphene, and raloxifene. These drugs tweak estrogen signaling, which can cause those sudden temperature surges. Now listen carefully: hyperglycemia, or high blood sugar, is another drug-induced issue. Offenders include tacrolimus, protease inhibitors, niacin, HCTZ, and glucocorticoids. Just remember this phrase: the people need high glucose. Then there's hyperprolactinemia, where prolactin levels spike due to drugs like typical antipsychotics such as haloperidol, atypical antipsychotics like risperidone, and also metoclopramide, methyldopa, and verapamil. This can lead to hypogonadism, presenting with symptoms like infertility, erectile dysfunction, or galactorrhea. Let's now touch on thyroid dysfunctions. Hyperthyroidism can be drug-induced by amiodarone, iodine, or lithium. On the other hand, hypothyroidism can also be caused by amiodarone and lithium, so just remember the phrase "I am lethargic." Before we wrap up this section, there's SIAD, which stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. It's caused by carbamazepine, cyclophosphamide, and SSRIs. This condition leads to water retention and low sodium, so to help you recall, use the phrase "can't concentrate serum sodium." Alright, shifting gears now, let's dive into gastrointestinal drug-induced disorders reactions, where the gut becomes the battlefield. We'll begin with acute cholestatic hepatitis and jaundice, most commonly linked to macrolide antibiotics like erythromycin. Next is constipation, and many medications are guilty here: antimuscarinics like atropine, antipsychotics, opioids, non-dihydropyridine calcium channel blockers, ranolazine, amiodarone, aluminum hydroxide, loperamide, ondansetron, and even vincristine. Let's not forget diarrhea, which can be quite disruptive. This is caused by acamprosate, various antidiabetics like acarbose, metformin, and pramlintide, also colchicine, cholinesterase inhibitors, lipid drugs like ezetimibe and orlistat, antibiotics like erythromycin, SSRIs, and chemotherapy agents such as irinotecan. Now listen carefully, one of the most serious GI toxicities is focal to massive hepatic necrosis, which can result from ingesting Amanita phalloides, the deadly death cap mushroom, as well as valproate and acetaminophen in high doses. Then there's hepatitis, which can be drug-induced by rifampin, isoniazid, pyrazinamide, and lipid-lowering agents like statins and fibrates. We also have pancreatitis, an inflammation of the pancreas, often triggered by diuretics such as furosemide and HCTZ, as well as glucocorticoids, alcohol, valproate, and azathioprine. Here's a phrase to help you remember: drugs generate a violent abdominal distress. And don't overlook medication-induced esophagitis, where pills damage the food tube. Offenders include potassium chloride, NSAIDs, bisphosphonates, ferrous sulfate, and tetracyclines. Think of this with the phrase pills not beneficial for food tube. This usually happens at narrow points in the esophagus and is more likely if pills are taken without enough water or while lying down. Finally, there's pseudomembranous colitis, which is a dangerous condition often caused by antibiotics like ampicillin, cephalosporins, clindamycin, and fluoroquinolones, and even PPIs. These drugs disrupt gut flora and pave the way for C. difficile superinfection. Alright, now let's dive into some hematologic drug problems, because when it comes to blood, even small imbalances can cause big problems. We'll begin with agranulocytosis, which is a dangerous drop in granulocytes, a type of white blood cell. It can be triggered by drugs like dapsone, clozapine, carbamazepine, propylthiouracil, methimazole, ganciclovir, and colchicine. A helpful mnemonic to remember this is, drugs can cause pretty major granulocytes collapse. Now moving forward to aplastic anemia, where your bone marrow basically shuts down. This can happen with carbamazepine, methimazole, NSAIDs, benzene, chloramphenicol, and propylthiouracil. To help you recall this, think, can't make new blood cells properly. Next up is direct Coombs-positive hemolytic anemia, which is a type of immune-mediated red cell destruction. It's caused by penicillin, cephalosporins, and methyldopa. Just picture Pooh classically munching on honey Coombs for a laugh and a memory boost. Let's now talk about DRESS syndrome, short for drug reaction with eosinophilia and systemic symptoms. This is a serious, T-cell, mediated hypersensitivity reaction triggered by drugs like phenytoin, carbamazepine, minocycline, sulfa drugs, allopurinol, and vancomycin. An easy phrase to recall this: DRESSes partially cover my skin and viscera, because this reaction affects both the skin and internal organs. Now listen carefully, if a person has G6PD deficiency, some drugs can cause dangerous hemolysis. These include sulfonamides, dapsone, primaquine, aspirin, and nitrofurantoin. So always screen for G6PD before giving these. Next is megaloblastic anemia, which involves abnormally large red blood cells due to impaired DNA synthesis. It can be caused by hydroxyurea, phenytoin, methotrexate, and sulfa drugs. Remember this with the phrase, you're having a mega blast with PMS. Let's not forget thrombocytopenia, or low platelets, which may be caused by heparin, quinidine, ganciclovir, vancomycin, and linezolid. These can increase bleeding risk significantly. And finally for this section, there are thrombotic complications. These are blood clots triggered by combined oral contraceptives, hormone replacement therapy, SERMs, testosterone supplements, and epoetin alpha. All of these increase blood viscosity and promote platelet aggregation, raising the risk of clots. Now let's shift gears into the world of musculoskeletal, skin, and connective tissue drug reactions, where side effects can strike bones, muscles, joints, and skin. To begin, there's drug-induced lupus, usually caused by hydralazine, procainamide, and quinidine. These can lead to a lupus-like syndrome with joint pain, rashes, and fatigue. Next is fat redistribution, especially in the form of lipodystrophy. It often happens with protease inhibitors and glucocorticoids. So just say, fat protects glutes, literally. Then we have gingival hyperplasia, or gum overgrowth. This can be triggered by cyclosporin, calcium channel blockers, and phenytoin. Here's an easy way to recall: can cause puffy gums. Let's now talk about hyperuricemia, or elevated uric acid levels, which can lead to gout. Culprits include pyrazinamide, thiazide diuretics, furosemide, niacin, and cyclosporin. Think of the phrase, painful toe and feet need care. Now listen carefully. Malignant hyperthermia is a life-threatening reaction to inhaled anesthetics, especially in people with a ryanodine receptor mutation. The antidote is dantrolene, so always have it ready during surgery. We also see myopathy, or muscle injury, with drugs like statins, fibrates, niacin, colchicine, daptomycin, hydroxychloroquine, interferon alpha, penicillamine, and glucocorticoids. These can cause muscle pain and even rhabdomyolysis in severe cases. Now let's talk about bones. Osteoporosis can result from long-term use of glucocorticoids, depot-medroxyprogesterone, GnRH agonists, aromatase inhibitors, anticonvulsants, heparin, and PPIs. These medications can weaken bone density over time, increasing the risk of fractures. Are you following me? Because now we're going into the sun-sensitive zone. Photosensitivity reactions, like sunburns with minimal sunlight exposure, can be caused by sulfonamides, amiodarone, tetracyclines, and fluoroquinolones. Here's a simple trick: SAT for photo. And then there's Stevens-Johnson syndrome, a severe and potentially fatal skin reaction. It's often triggered by antiepileptic drugs, especially lamotrigine, as well as allopurinol, sulfa drugs, and penicillin. Remember this chilling line: Stevens-Johnson has an epileptic allergy to sulfa and penicillin. We also have teeth discoloration, which is most famously caused by tetracyclines. A good way to recall this: tetracyclines, because they stain teeth, especially in kids. And finally, we wrap up with tendon and cartilage damage, a risk with fluoroquinolones, especially in older adults and those on steroids. Always be cautious with these, particularly in athletes or the elderly. Now let's enter the brain zone. Yes, it's time to explore neurologic drug reactions, where medications can mess with your head, nerves, and even your senses. We'll start with synchonism, a strange-sounding condition caused by quinidine and quinine. It can present with tinnitus, hearing or vision loss, psychosis, and cognitive impairment. So if a patient's seeing things and hearing bells after taking these drugs, think synchonism. Next is a Parkinson-like syndrome, triggered by antipsychotics and metoclopramide. It involves cogwheel rigidity, especially in the arms, and resembles classic Parkinson's symptoms. Don't be surprised if the patient starts shuffling. Now listen carefully: peripheral neuropathy, that pins and needles pain in the hands and feet, can be caused by platinum agents like cisplatin, as well as isoniazid, vincristine, paclitaxel, and phenytoin. Just remember, cis, it's very painful peripherally. Moving on, we've got idiopathic intracranial hypertension, which means increased pressure inside the skull without a clear cause. This may happen with corticosteroids, danazol, vitamin A, growth hormones, and tetracyclines. Try this mnemonic: crime and debt always grow head tension, because these drugs raise brain pressure. Next up are seizures, and yes, some drugs can lower the seizure threshold. Offenders include isoniazid, bupropion, imipenem/cilastatine, and tramadol. So here's a quirky line to help you remember: with seizures, I bit my tongue, B for bupropion, I for isoniazid, T for tramadol. Now let's talk about tardive dyskinesia, a delayed movement disorder that includes repetitive facial movements and tongue thrusting. It's usually caused by long-term use of antipsychotics and metoclopramide. These effects can linger even after stopping the drug. Are you following me? Because now we're heading into visual disturbances. These are triggered by a whole list of drugs. Topiramate causes blurred vision and halos, hydroxychloroquine affects visual fields, digoxin gives you yellow-tinged vision, isoniazid causes optic neuritis, ivabradine creates luminous phenomena, PDE5 inhibitors like sildenafil make everything look blue, and ethambutol messes with color vision. To remember all these, just say, these horrible drugs irritate precious eyes. Now, take a deep breath, because we're diving into renal and genitourinary reactions. We start with Fanconi syndrome, a type of proximal tubule dysfunction that can be caused by cisplatin, ifosfamide, expired tetracyclines, and tenofovir. These drugs waste important substances in the urine and leave the kidneys struggling. Then we have hemorrhagic cystitis, a painful bladder complication often seen with cyclophosphamide and ifosfamide. But don't worry, this can be prevented by giving mesna, which protects the bladder lining. Next is interstitial nephritis, which presents with fever, rash, and eosinophils in the urine. It's commonly caused by diuretics, P for NSAIDs, P for pain-free, penicillins, PPIs, rifampin, and sulfa drugs. To remember them, think of the 5 Ps. Now listen carefully, nephrotoxicity, or direct kidney damage, can result from cisplatin, aminoglycosides, amphotericin B, and vancomycin. Monitor creatinine closely with these nephrotoxic agents. Now take another deep breath, because we're talking about the lungs next. The most famous reaction is the classic dry cough caused by ACE inhibitors. It's persistent, nagging, and dry as a desert. Then there's pulmonary fibrosis, or scarring of lung tissue, caused by drugs like methotrexate, nitrofurantoin, carmastine, bleomycin, busulfan, and amiodarone. These drugs literally make it harder for you to breathe. Try this phrase, my nose cannot breathe bad air. And finally, let's wrap it up with multi-organ drug reactions, where one drug can affect several systems at once. Antimuscarinic effects like dry mouth, urinary retention, and blurred vision can come from atropine, tricyclic antidepressants, H1 blockers, and antipsychotics. These block the parasympathetic system, leading to classic drying symptoms. And last but not least, the infamous disulfiram-like reaction, which makes you feel violently ill if you drink alcohol while taking certain drugs. This reaction is triggered by first-generation sulfonylureas, procarbazine, some cephalosporins, griseofulvin, and metronidazole. Just remember, sorry pals, can't go mingle, especially if alcohol is involved. Now listen carefully, because we're about to explore the fascinating world of drugs that affect pupil size and those that interact with the cytochrome P450 system, and yes, we'll end with a warning about sulfa drugs you should never forget. Let's begin with the pupil. Drugs can either cause the pupil to dilate, which we call mydriasis, or to constrict, which is known as miosis. Mydriasis is typically caused by anticholinergics, such as atropine, tricyclic antidepressants or TCAs, tropicamide, scopolamine, and even some antihistamines. But it doesn't stop there. Indirect sympathomimetics like amphetamines, cocaine, and LSD, and even the opioid meperidine, also expand the pupil. You'll also see mydriasis with direct sympathomimetics that stimulate the sympathetic nervous system directly. On the flip side, miosis or constricted pupils can be caused by sympatholytics, especially alpha-2 agonists, and by opioids, although meperidine is the one odd exception. Constriction also occurs with parasympathomimetics, like pilocarpine, and with dangerous substances like organophosphates. Here's how the muscles work. Radial muscle contraction, driven by alpha-1 receptors, leads to dilation, while sphincter muscle contraction, mediated by M3 receptors, results in constriction. So whether the eye opens wide or squeezes shut depends entirely on which pathway is activated or inhibited. Now, let's shift our focus to something every good clinician needs to grasp, the cytochrome P450 enzyme system, which is essential for drug metabolism. Some agents are inducers, others are inhibitors, and many drugs are simply substrates that get metabolized by this system. To recall the common inducers, remember this mnemonic: St. John's funny fen mom never refuses greasy carbs and chronic alcohol. That refers to St. John's wort, phenytoin, phenobarbital, modafinil, nevirapine, rifampin, griseofulvin, carbamazepine, and of course, chronic alcohol overuse. These inducers speed up metabolism, potentially lowering drug levels too much. Then we have the substrates, drugs that depend on this enzyme system for clearance, including theophylline, oral contraceptives, antiepileptics, and warfarin. You can remember them with this phrase: the OCPs are anti-war, because messing with their metabolism can trigger unplanned pregnancies or dangerous bleeding. Finally, let's not overlook the inhibitors, which slow down the system and can dangerously raise drug levels. These are remembered with the mnemonic "sick faces come when I am really drinking grapefruit juice." That stands for sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, acute alcohol overuse, chloramphenicol, erythromycin, clarithromycin, sulfonamides, ciprofloxacin, omeprazole, amiodarone, ritonavir, and of course, grapefruit juice itself. These agents can make a harmless dose of another drug suddenly toxic. Now let's talk about sulfa drugs, which are particularly important because of the risk of allergic reactions. These include sulfonamide antibiotics, sulfasalazine, probenecid, furosemide, acetazolamide, celecoxib, thiazides, and sulfonylureas. A helpful phrase to remember them is scary sulfa farm facts. And you should definitely remember the risks. Patients with sulfa allergies may suffer from fever, urinary tract infections, Stevens-Johnson syndrome, hemolytic anemia, thrombocytopenia, agranulocytosis, acute interstitial nephritis, hives or urticaria, and even photosensitivity. So always screen carefully before prescribing anything from this category. Now let's talk about drug name endings and what they tell us about a drug's category and function. This is a powerful way to decode pharmacology on the go. Starting with antimicrobials, drugs ending in -asver are NS5A inhibitors like ledipasvir, while those ending in bendazole are antiparasitic or antihelminthic agents, like mebendazole. If you hear buvir, think of NS5B inhibitors like sofosbuvir. The ending -silin refers to transpeptidase inhibitors, as seen in ampicillin. The suffix conazole is for ergosterol synthesis inhibitors like ketoconazole, and cycline is for protein synthesis inhibitors such as tetracycline. Moving on, drugs ending in floxacin belong to the fluoroquinolone family, like ciprofloxacin. Mivir means it's a neuraminidase inhibitor, such as oseltamivir, and navir signals a protease inhibitor like ritonavir. The ending -over is typical for viral DNA polymerase inhibitors like acyclovir. Drugs that end in -previr are NS3/4A inhibitors, like grazoprevir, while those ending in -tegravir are integrase inhibitors like dolutegravir. Finally, thromycin points to macrolides such as azithromycin. Now are you ready for the antineoplastic drugs? If it ends in -case, it's a recombinant uricase like rasburicase. Mustine means it's a nitrosourea, like carmustine. The suffix platin tells you it's a platinum compound, as in cisplatin, and pozide means a topoisomerase II inhibitor, like etoposide. Rubicin refers to anthracyclines like doxorubicin, while Taxol is a taxane, like paclitaxel. Finally, Tecan points to a topoisomerase I inhibitor, such as irinotecan. Let's move to CNS drugs. Flurane is the hallmark of inhaled anesthetics, such as sevoflurane. For atypical antipsychotics, you'll often see apine or idone, like in quetiapine and risperidone. Typical antipsychotics, on the other hand, end in azine, like thioridazine. Barbitol is used for barbiturates, such as phenobarbital. VMAT inhibitors end in benazine, like tetrabenazine. Caine refers to local anesthetics, like lidocaine. Capone is the suffix for COMT inhibitors like entacapone. For non-depolarizing neuromuscular blockers, look for curium or curonium, like atracurium and pancuronium. The suffix -gyline tells you it's an MAOB inhibitor, like selegiline. TCAs end in ipramine or triptyline, such as imipramine and amitriptyline. Triptan drugs are 5-HT1B and 1D agonists, such as sumatriptan. And finally, zepam and zolum refer to benzodiazepines, like diazepam and alprazolam. Now let's talk about autonomic drugs. The suffix -col means it's a cholinergic agonist, such as bethanechol. Olol marks a beta blocker, like propranolol. Stigmine is for acetylcholinesterase inhibitors, like neostigmine. Pterol indicates a beta-2 agonist, such as albuterol. And zosyn tells you it's an alpha-1 blocker, like prazosin. Now shifting to cardiovascular drugs, if it ends in -afil, it's a PDE5 inhibitor like sildenafil. Dipine means it's a dihydropyridine calcium channel blocker, like amlodipine. Parin indicates a low molecular weight heparin, like enoxaparin. Place is a thrombolytic agent, such as alteplase. ACE inhibitors end in -pril, like captopril, while angiotensin II receptor blockers end in -sartan, like losartan. Zabin signals a direct factor XA inhibitor, like apixaban. When we look at metabolic drugs, gliflozin means it's an SGLT2 inhibitor, like dapagliflozin. Glycine is a meglutidenide, like repaglinide. Gliptin marks a DPP4 inhibitor, such as sitagliptin. Glitazone points to a PPAR-gamma activator, like pioglitazone. Glutide drugs are GLP-1 analogs, like liraglutide. And finally, statin drugs are HMG-CoA reductase inhibitors, as seen in atorvastatin. Now listen carefully, because we're moving to a few other essential categories. If you hear caftor, that's a CFTR modulator, like lumicaftor. Dronate means it's a bisphosphonate, such as alendronate. Lucast indicates a cysteinoleucotriene receptor blocker, like montelukast. Lutamide is an androgen receptor inhibitor, like flutamide. Pitnet means it's an NK1 blocker, such as aprepitant. Prazole is the classic proton pump inhibitor, like omeprazole. Prost marks a prostaglandin analog, like latanoprost. Centan means it's an endothelin receptor antagonist, such as bosentan. Cetron refers to 5-HT3 blockers, like ondansetron. Steride is a 5-alpha reductase inhibitor, such as finasteride. Tidine is an H1 antagonist like loratadine, while tidine indicates an H2 antagonist like cimetidine. Trozole is used for aromatase inhibitors, such as anastrozole, and vaptan marks ADH antagonists, like tolvaptan. Now, are you still with me? Because we're ending with biologic agents, which are absolutely vital in modern medicine. Drugs that end in -mab are monoclonal antibodies, and their prefixes tell you more. If it ends in -zimab, it's a chimeric human-mouse monoclonal antibody, like rituximab. Zumab means it's a humanized monoclonal antibody, such as bevacizumab. Umab tells you it's a fully human monoclonal antibody, like denosumab. Now, when you hear IB, know that it's a small molecule inhibitor targeting intracellular molecules. For example, ciclib means it's a cyclin-dependent kinase inhibitor, like palbociclib. Coxib marks COX-2 inhibitors such as celecoxib. Parib is for PRP inhibitors like olaparib. Rafinib signals a BRAF inhibitor, like vemurafenib, and tinib marks tyrosine kinase inhibitors like imatinib. Lastly, zomib indicates a proteasome inhibitor, such as bortezomib. And don't forget about the interleukin receptor modulators. These end in kin and can act as either agonists or antagonists. For example, leukin refers to interleukin-2 agonists or analogs, like aldesleukin, while kinra is used for interleukin receptor antagonists like anakinra.